When you need medical help fast, use NHS 111 online to go from home to an urgent treatment centre.
Mr. Williams, please come through.
Or a pharmacy.
Hello, pharmacist will see you now.
Or if needed, stay where you are and get a call from a nurse, doctor, or paramedic. Get assessed and directed to the right place for you in as little as 90 seconds. Use NHS 111 online.
This is the North East and North Cumbria Providers Podcast, highlighting the fantastic work taking place across the region to provide the highest quality of care.
Hello and welcome to the latest episode of the Providers Podcast. I'm your host, Harry Newhouse, Communications and PR Officer for the North East and North Cumbria Provider Collaborative. Today we're talking about single point of access, which used to be known as Advice and Refer. This is a digital service that is transforming how GPs and hospital specialists communicate. It allows GPs to seek rapid specialist advice on treatment plans, test results, or whether a full referral is needed. Often this means patients get the care they need more quickly, sometimes within 24 hours, and avoid unnecessary hospital appointments. Here in the North East and North Cumbria, single point of access has played a key role in helping us deliver some of the strongest gastroenterology performance nationally. Joining me today are Richard Sterry, who is the Head of Performance and Improvement, Dr. Matthew Warren, who is a consultant gastroenterologist, and Dr. Richard Thomson, who is also a consultant gastroenterologist and clinical subdean. They are all from Northumbria Healthcare NHS Foundation Trust, and welcome to you all. Great to have you with us.
Thanks, Harry. Yeah.
So to start off, could each of you introduce yourselves and tell us a bit about your roles at Northumbria Healthcare?
Hi, I'm Matt Warren. I've been a consultant gastroenterologist in Northumbria Trust for about 20 years. For the last few years, I've been really interested in how we improve access for patients to specialist advice and also reduce the waiting times to outpatient clinic appointments. And I've been working with Richard and also primary care colleagues on trying to improve that service across the region, but also now we have a role with NHS England to try and help other teams across the country who are looking to deliver a SPOA, the single point of access that you spoke about.
Hi, I'm Richard Thomson. I'm a consultant gastroenterologist. I've been here for 26 years now. I have a kind of broad training as a general gastroenterologist, but my clinical interest now is bowel cancer screening. I've got a long background in undergraduate education, and I guess I'm an enduring interest in teaching good medicine. And this project really appealed to me from that point of view, and I would say for the last 3 years or so this has been the main focus of my clinical work.
I'm Richard Sterry. I'm Head of Performance and Improvement at Northumbria Healthcare. So my role is broadly in two parts. So firstly around performance, which includes elective pathways and our performance standards that we report nationally, and single point of access is a core part of that. And then the other half of my role is around improvement. So how do we develop services using an improvement approach to continuously deliver better care for patients across our services and all of our specialties. And my interest in this came about when I was formerly the operational manager for gastroenterology in the Trust, working alongside Richard and Matt, when we brought this in as the first specialty in the Trust 3 years ago now.
Brilliant. And I briefly talked about what single point of access was at the beginning, but for those who might not be familiar, what exactly is a single point of access and how does it work in practice for clinicians across the region?
So traditionally, colleagues in primary care would refer patients to us to be seen in the outpatients department. There was very little clinical review of those referrals early in the pathway, so patients would often have to wait a long time to come and see us in clinic, sometimes ending up in the wrong clinic, sometimes really with conditions that we could have treated remotely, if you like, or through supporting the GPs. Sometimes those conditions could have been treated many months before the patients ended up in clinic. So we felt that that was too slow for patients, really. And so initially we set up advice and guidance, which is where GPs can just run questions, areas of uncertainty, inquiries past us. And then a couple of years ago, we decided that there really wasn't much of a difference between the referrals we were receiving through that advice and guidance process and also through the traditional referral pathway. They really were very similar. So we combined the two pathways into one. So that's the single point of access, the SPOA. What that means is that every referral, be it for advice or for an outpatient appointment, comes into one portal, is dealt with rapidly by senior decision makers, consultants in our case, and the aim is to help patients navigate through their healthcare or navigate their healthcare more quickly, getting them to the right test first time, the right consultant first time, or in many cases, discussing with the GP how that care might be delivered closer to home. So it's a sort of technical, the SPOA is a technical solution to facilitate a clinical discussion between primary and secondary care.
How does single point of access improve patient experience and the speed of care? So, for example, avoiding unnecessary outpatient appointments or helping GPs access specialist support more quickly?
Yeah, so in the conventional model that Matt describes, I think patients spent a lot of time in limbo, so uncertain as to when they were going to be seen, stuck anxious about the symptoms which may be unpleasant and impacting on their lives, and just stuck for unnecessary length of time. And in the SPOA model, because we're delivering expert opinion really early on in the pathway, we've really shrunk the amount of time that people are waiting, but also getting them the right answer as quickly as possible. So a common example would be abnormal test results. So X-rays that have some query about the report. Conventionally, the referral would have been made, the patient would have sat on a pile, as Matt says, without any clinical review until the point the patient walks through the clinic door. And all that time, they're anxious. This way, we can see the report, we can give our opinion, we can see it in the context of the patient's symptoms, for example. We can run it by a second radiologist and kind of clarify how concerned we should be. If further investigations are needed, we can arrange those directly, and then we can write to the patient with reassurance, and if they need to be seen, we can make sure that they see the right specialist with that interest, so that they are avoiding unnecessary appointments. So the whole thing is faster, it's more logical, and we're keeping the patient and the GP in the loop.
It's really helped for our region to be one of the top performing gastroenterology services nationally. So how has it contributed to this success?
Yes, it's a really good question, Harry, and we've got a number of trusts across North East and North Cumbria who are in the top performing gastroenterology services, but also more broadly for referral to treatment performance overall, which is great to see as a region. And I think this whole process started with a motivation of doing things better for patients in terms of waiting times, but also the quality of advice as well. So some patients will be seen in clinic still in a very traditional outpatient model, but there will be instances there where we have done things such as front-loading diagnostics, such as blood tests and scans. So actually that first outpatient appointment is much more meaningful. They don't just turn up to the appointment and then get all the diagnostic tests when we know that from the point of referral they'll need that. Some patients may not need to be seen by secondary care, and that does challenge the concept of what would have been a very traditional outpatient model several years ago in gastroenterology in Northumbria. And I think for us what this has really allowed us to do is get the right patient in the right place at the right time, and that is a very, very broad concept, but it comes down to what Richard and Matt have described around front-loading this senior medical expertise way before the outpatient appointment and making sure it's placed correctly. And this has been a journey for us, and this has been something that has evolved over time. We went live with this in June 2023. There was several months of planning and discussion before that, and it's a model that's still stood the test of time really, sort of 3 years later. It's still something that we're very proud of, and we've been very fortunate to be in a position where this has been rolled out to other specialties and indeed to other trusts, both locally and more broadly across the country as well.
Yeah, and so you mentioned there that single point of access is about getting the right patient at the right time at the right place. So do you have any examples of or cases of those scenarios that it's helped the patient?
Yes, sure. I mean, a very common scenario, as Matt alluded to, where the patient's symptoms are actually being driven by medication that they're taking for another condition, and that may not be obvious to the referrer, but because we see a lot of this, it's apparent to us, and we can offer very quick advice to have a trial off the medication. Another good example would be we see a lot of patients with anemia, and some of those definitely need to be investigated, and some of them it's a more nuanced decision. And waiting for months to see somebody to have that conversation is a waste of the patient's time. And we can weigh up the risk of the patient. We can offer an estimation of the pros and cons of investigating. We can hand that information back for the consideration of the patient and the GP. They can have a sort of shared decision making process, and then we can allocate them to either investigation or for watchful waiting. And we had lots of positive feedback from GPs and patients about that. They like being empowered to make those decisions. They like the sense that there are several professional eyes on the problem, and that the door is open. So if there's a change of condition or something remains a concern, then they can come back to us.
So you mentioned there some of the positives it has for GPs and specialists. So from their perspective, how has a single point of access changed ways of working?
So I think this is really crucial, because GPs are absolutely our partners in this work, and none of us here is a GP, so it's difficult to kind of speak on their behalf. But what we can say is that we've done some surveys, and they really highlight the kind of tightrope we have to walk as providers of SPOA to deliver for the patients, but not destabilise primary care, destabilise secondary care, push work around from one place to the other. That's a very, very tricky path to follow. And what our local GP survey tells us is that in a very significant majority of cases, the GPs like advice and refer, SPOA as it's now called, but they acknowledge that it holds work in primary care that would have traditionally been done in secondary care. So if we do it right, if we do SPOA correctly or properly or in a way that works for primary care, they're happy with it. They like it. They see the benefits for the patients. They see some benefits for themselves. But if we get it wrong, if we're rude or discourteous, or if we push too much work back into primary care, well, we might make our clinic performance look better, but we can actually destabilise primary care. We can push too much onto them without appropriate funding. So I'm kind of labouring the point really to say that it's a constant checking process to make sure that we're trying to do what's best for the patients, but in a way that's sustainable for the whole health system. From our point of view as SPOA triagers, this is additional work that we weren't doing before, but I feel the same as I hope the GPs do. I feel it's valuable work. I feel that it does help patient care in many, many instances, and so it's work that I find engaging and rewarding to do, even though it is hard. So I think fundamentally we believe, and I think in many cases our GPs and the patients believe, that this model does improve healthcare for them, but we have to absolutely recognise that there is a work impact on all, both the referrer and the triager.
And what does this mean for capacity, waiting times, and overall system efficiency?
Yeah, so there's a whole load of considerations that go with this around how we optimise capacity. So we know that services are working under pressure, so rising demand, rising complexity, patient expectation to often be seen earlier as well, chronic disease management. So in terms of capacity, we've really been able to optimise our capacity, and this has been a redistribution of resource, so working out where that senior medical expertise is best placed, and for us we've decided that is very much at the front door of the pathway at day 0, as opposed to potentially week 20, 30 or 40, where actually time is of the essence. If we want to ensure timely diagnostics, timely advice, that has to be placed right at the start of the pathway and not later in the pathway. So from a capacity point of view, we've really considered how much capacity we need to place within the single point of access service, and that has meant that in some instances we've switched outpatient clinics to single point of access for clinicians to provide advice earlier where it's needed. In terms of waiting times, it's allowed us to really ensure we have a very short waiting list. So our waiting list for a first appointment within gastroenterology is 4 to 5 weeks. There is some variation around that depending upon geography and frequency of clinic. And similarly, this isn't something that we've seen as a benefit just in gastroenterology, but in wider specialties as well. And we've seen some specialties that have really ran with this and had huge benefit from bringing in their waiting lists. And again, it's following the same principle of where's that senior medical and clinical expertise positioned in the pathway. In reality, these patients were still going to be seen. It was just at a much later point. So having a really lean pathway has really allowed us to improve efficiency, but also patient experience. And I think also team experience as well, of having a more satisfying outpatient clinic, of not spending perhaps the first couple of minutes of the appointment apologising for the length of time for the wait. We can see patients are turning up. They've often got now scan results, blood results, endoscopy results, and actually that means for a much more meaningful outpatient consultation.
But I think, Richard, if I can come in, I think there's also impacts there on the outpatient clinic themselves. So the patients who come to clinic are often more complex. We're never really seeing people just to say, oh, you've had some tests and they were normal. We're always seeing people where we think that the face-to-face encounter adds value and is necessary. We're trying to respect patients' time and having to take time off work and all that kind of thing. So I think for the clinicians, it does mean that clinic can become more complicated. I think there's a real discussion to be had between clinicians and managers when SPOA is really up and running and backed up by the follow-up validation work that I know you've been doing, to say that maybe we can't see as many patients in clinic as we did before because they all need more time than they did before. So I don't know, I think there are massive advantages to this, but I think we've got to be very mindful of sort of unintended outcomes as well, and making sure that the clinicians aren't having to do this kind of work in a rush or whatnot is important. Similarly, job planning, the SPOA time is super important as well, isn't it? This is difficult work and can't be squeezed into a consultant's job, in amongst being the consultant of the day on call or anything like that. It's got to be properly job planned, properly resourced, properly selected team, all that kind of thing.
But we've also had thoughts, haven't we, about how to make that time more purposeful. So we talk a lot about field notes, so that these are notes that help to guide the person seeing the patient in clinic, what the focus of the encounter should be, and summarise what we already know about the patient. And increasingly we want the patient to know what we're intending, so they have some, and they can prepare questions and they can anticipate what's going to happen in the encounter. But as Matt says, it's efficient, it's purposeful, it's the best use of everybody's time, but it's hard work, and that there may be implications for how much hard work can be done in one session without burning people out.
I think just to develop that about the field notes idea, one of the things that perhaps we didn't realise until relatively recently, and lots of teams don't realise, is that in many cases the patients can see the SPOA response that we give to the GP. Now, it's not automatic, but what that means is, first of all, we have to be very alert to the fact that patients can read what we are saying to primary care. I like that because it keeps the conversation polite and respectful. It also allows us to kind of signpost the patient, as Richard said, to what we're thinking is going on. We can provide self-management information through that response, links to various NHS resources and whatnot. But I think it might also feed a little bit into the waiting well agenda. You know, if you're working in a team that has a 6-month wait for clinic, let's say, well, under the traditional model, we would have accepted that referral, and the patient is then, as Richard has said earlier, in limbo for 6 months, not knowing what's going on, potentially contacting their GP every so often saying, well, what happens now? And we know that GPs are very burdened by chasing up appointments, managing patients on waiting lists, all that kind of thing. What we hope now is that if the field notes are visible to the patient, that might give them some things to be thinking about, working on, self-management, information, and just kind of feeds into that sense that we've picked up from patient feedback surveys that they don't like this sense of being lost in the wilderness between primary and secondary care and not knowing where to turn. So it's not the solution to that problem because the patient's ability to read it is not guaranteed. It requires the GP to upload the response onto the summary record and then the patient to access it through the NHS app. But we understand that many patients are doing that, and I love that way of sort of not really bringing the patient into the conversation, but of the patient being aware that an interprofessional discussion is going on. I think that's really been something I was a bit scared about when I first heard about it, because I was worried what I might have said in responses previously, but now I really like it.
Matthew and Richard, as clinical leaders, what does the adoption of this digital approach mean for the future of gastroenterology and other specialties?
Yeah, so change is difficult, and maybe especially difficult for a conservative profession like medicine. It's conservative for good reasons. You know, we're not early adopters of fads, but and people are, you know, very wedded to their traditional way of doing things. But it's apparent that, you know, if that results in normalising people waiting for months or years to be seen, then it's not working, and we need to do things differently. But this has big implications for the culture of medicine, and that starts the way we're trained, very much wedded to having one patient in front of us, being able to ask them questions and have a face-to-face conversation, to be able to lay hands on the patient and examine them. This is, you know, 1,000-year-old medical culture, and so you can understand people's reluctance to move away from that, and there are big implications for training. But I would say that really this is more about adapting expertise, adapting the skills and aptitudes that people already have, but just applying them in a different context. So you know, the basics of gathering information, of clinical reasoning and making safe judgments and communicating that information, that's all there in traditional medical training, but we're just asking people to adapt those skills to a modern context.
And I think it fits in really nicely with some of the kind of NHS planning agendas, if you like. So we've got the 10-year plan, and one of the left shifts from hospital to community. I think SPOA can be part of that conversation. I think also we've got the medium-term planning framework that came out earlier this year, which is really heavily leaning on SPOA as a must-do, if you like, rather than a nice-to-have. So I think SPOA is coming. I think the SPOA implementation guidance came out a week or two ago and is very helpful, but I know has created some anxiety in secondary care, but also a lot in primary care. And I think it's really incumbent on us to kind of work together with primary care to make sure that, you know, fundamentally this works for the patients. But of course, it also works as part of a sustainable health model. As I've said before, we can't implement all of this as providers, push potentially a load of work back into primary care and sink an already overstretched GP service. We've got to be mindful. So I think that kind of collaboration, that working together, is going to be absolutely key. Personally, I really like it because it gives me, I think, the opportunity to try and if you like, offer support, offer advice, offer specialist opinions to people who I would never need to see in clinic. Maybe the GP sees a patient and says, I'm just not quite sure about this one, I don't need to refer them, but I'm a bit worried. Great, SPOA allows that GP to ping in a request to me, I don't really want you to see this person, but can you just sense check this for me or give me a pointer? I love that. That's absolutely why I got interested in this. And to me, it's the equivalent of the kind of, I would walk down the corridor and have a conversation with a colleague. I'll go chat with my mate who's a cardiologist or something like that. I wanted GPs to have that opportunity or that access to us in that same kind of low-level conversational style. And it doesn't always work, but I think it works a lot of the time. So I think Richard's absolutely right that there are big educational and training requirements. This way of working isn't for everybody. There's a lot about risk, there's a lot about medico-legal stuff, there's a lot about the ways we were trained to work that this doesn't quite align with, and we have to adapt. But I think both in terms of the NHS structures and the NHS plans, I think this absolutely can be part of that. And I think fundamentally it gives us in secondary care a real opportunity to sort of reach outside of our traditional footprint, almost getting into the realms of preventative or public health medicine, which I find, at this stage of my career to be a very appealing bit of work to get involved in.
What's next for single point of access, and are there opportunities to expand it, refine it, or bring more specialties on board?
I think we've demonstrated through our internal work that other specialties can adopt this approach successfully and reap the same benefits that we've seen in gastroenterology. And we are now starting to reach out beyond Northumbria through our work with NHSE, and we have certainly seen evidence of very different teams in very different contexts adopting the principles of this work with success. So we certainly have confidence that this is a scalable model. In terms of opportunities going forwards, I think we're just beginning to understand what good really looks like, and the training implications that we've talked about, relationships between secondary care clinicians and their primary care colleagues, between secondary care clinicians and their managers, this is very much relationally dependent, and I think one of the things we're really interested in is how to support those strong relationships, because that seems to be key to making this work.
And backing the enthusiasts as well, isn't it? I mean, I think one of the things that we found working with Richard is that kind of clinical managerial, getting the enthusiasts together, and we're very fortunate to have some local GPs who've worked a lot with us on this as well. I think that's been absolutely fundamental to this work, hasn't it? If each group worked in isolation, or if clinicians worked at odds with managers, it just wouldn't work as well at all. So I think, the future of SPOA is that everybody's got to do it, really. Under the conditions of the medium-term planning framework, everybody's expected to do it by April 2027. That's a big ask, and I think really the challenge is to do it well, and to make sure that it works for the patients, it works for the GPs, it works for secondary care. And quite how we do that, quite what good looks like, as Richard says, well, I think that depends from location to location, that's different from specialty to specialty. But I think there are so many fundamentals that apply to everybody. I think there's more that unites us than divides us, if that makes sense. So it's got to be locally implemented in partnership, but based on those really key principles of communication, patient-centred, clinical outcomes. I would say this because I lived my whole life trying to sort of work out what good looks like and make it work for everybody, but I think there's huge opportunity here. But equally, I think if we do it badly, there's huge risk. So I think that's the key.
I think that's a nice way to finish the podcast. So thank you all for joining me today and sharing your insight in single point of access and how it's helping transform patient care across the region.
Thanks for joining us for this episode of the Providers Podcast. Hit subscribe to keep up to date with the latest news and catch up with what we've been up to on our website and social media pages.